I'm going to take you through a clinical case, and I'm actually going to take you quite slowly. I think also what I want to present to you around this is the case study in the broader context. So I'm going to kind of diverse a little bit or sidetrack a little bit, but I want you to bear with me because I'd like you to understand a little bit more around the setting in which I practice, which I guess is probably quite different to the settings that many of you are practicing in currently. Okay. Can I have the next slide, please? It's not advancing. Thank you. So these are my disclosures.
It's not working?
Not working for me.
So next slide, and then we'll have someone look at this in the meantime.
Thank you. All right. So South Africa is, for any of you who have been there will know that it's a country of massive diversity. We have diversity in our culture. We have a diversity in terms of, are we using this one? Okay, thank you. Okay, thank you. So there's a massive diversity within the country, and nowhere do we actually see this more as well as within actually our healthcare setting. So what we tend to have in South Africa is we have this dichotomy of practices. We have a public health sector which is very much focused around guidelines, and this is obviously where the majority of our patients are managed. In fact, more than 80% of patients are managed within our public sector setting. And then we have a smaller sector, less than around about 17% of patients would be managed within our more private care sector. So what we tend to have is we have two sets of guidelines going. Now, please remember that in South Africa, being a resource-limited setting, we do very much focus around guidelines in the management. We use a public health approach as advocated by the WHO. So we do tend to have these two sets of guidelines. We have our Department of Health set of guidelines, and then we have the Southern African HIV Clinician Society, which also sets up a set of guidelines, which usually differ somewhat from the public health sector guidelines in that these guidelines tend to be a little more wide-ranging and offer more diversity within them and more options in terms of when you're treating a patient. And the reason I want to bring this up is plain and simply because that sometimes does impact the way in which patients may be sequenced through care and how they are managed. Also importantly, though, is when we have guidelines that are set up by the Clinician Society, for example, we do try to straddle across the public and the private sector, because the other thing that tends to happen in South Africa is as people's circumstances change, so they may at one stage have medical insurance and may be managed in the private sector, then they may, for example, lose their employment and then they end up transitioning back to the public sector. So as we've developed along the road of developing sets of guidelines within South Africa, we also try to be cognizant that although we have these two sets of guidelines, there should not be too much disparity between them because of the fact that patients may have to transition from the one sector to the other. The other thing is that when we develop guidelines for the Clinician Society, we also try to be a little bit more aspirational, recognizing that the guidelines may be adopted by other countries within the region, and within the region there may be some disparity in terms of what resources are available, in terms of the drugs available and the monitoring. So that's the background I want to give you before I actually start taking you through the case of this particular patient. So if you have a patient in South Africa, this would be the lines of management that we currently have if for a patient who's managed, for example, in the public sector. So a fairly standard, at the moment, NNRTI-based first-line regimen, efavirenz-based, really aligning with what the WHO recommendations of. When a person fails first line, we don't do genotyping in South Africa. That would be around the cost of the test for the one thing. Secondly, because we're using the public health sector approach and we kind of know what we would expect when we see a first line failure, we use the sequencing and we move on to a second line protease inhibitor-based regimen. Currently in South Africa, the main protease inhibitor regimen that we would use in second line would be lopinavir-based. The reason for that being in South Africa, we don't actually have a co-formulation of atazanavir, ritonavir available, so it's really for around simplicity for the patients and for ease there. And then if a patient does actually fail second line, at this point we would do a genotype test before determining what would happen and how they would be managed in a third line regimen. And our current third line regimens would include for every patient the protease inhibitor darunavir, it would include an integrase inhibitor, and it would include traverine, possibly depending on scores, which I'll talk about a little bit later, and usually we would include two nucleoside reverse transcriptase within that third line regimen as well. Just in terms of contrasting, in terms of what the Clinician Society guidelines, you can see these guidelines are actually fairly similar. The difference being here is that we offer more options in terms of the third drug used in a first-line regimen, where we have not only efavirenz being recommended, but now with the latest sets of guidelines, which were actually just released 1 week ago, in fact, including the introduction of dolutegravir into first line, and of course the possibility of using rilpivirine in patients starting with a low viral load as well. Second line looks pretty much the same as in the public sector, only in second line in the Clinician Society guidelines, we would prefer the use of atazanavir. And in fact, once darunavir 800 milligram formulation becomes available in South Africa, that would be our preferred protease inhibitor for second line regimen. And again, the third line regimen looks very similar to what it does in the public sector, where most patients would get darunavir. And again, this would be genotype determined. Even in the private sector, when you fail first line, we don't do a genotype, but in transitioning from second to third line, this is always done on the basis of a genotype test. So just in that kind of a background, and remembering especially in a lower and middle income country like South Africa, no matter how good the ARVs are, there are so many other things, and it is much the healthcare sector which is going to determine whether or not a patient may virologically suppressed as much as it may be down to the ARVs themselves. Okay, and as you can see that both in terms of both the public sector and the Clinician Society guidelines, in fact, it's very much following for first line what the WHO recommendations are. The one thing we haven't introduced in either the public or the private sector in South Africa is the recommendation around the efavirenz 400 as an alternative option, and that's really around the lack of TB and pregnancy data and whether or not but I mean, we've got studies that will be coming to answer that question, and also the lack of co-formulation. Okay, so I'm going to take you through a case of resistance. The other thing I'd like to just put to you as well is to remember that in South Africa, our first integrase inhibitor, raltegravir, was approved around about 2009, 2010. But in that time, the use was very, very limited in that it was initially only introduced within the private sector. And in fact, there's been very little use of raltegravir within the public sector. And then dolutegravir was licensed last year in South Africa in July. So there's been very limited amounts of exposure to integrase inhibitors within South Africa, and particularly more so within the public sector. It's been very limited. So I want to take you back in time to our patient and right back to 2006. Now, the other thing to bear in mind is our very first set of public sector guidelines in South Africa came out in 2004. So please bear in mind the times that we're going to be working through. And then from 2004, those guidelines were not updated until 2010. So for a long time, that initial rollout of antiretroviral therapy within the public sector in South Africa was pretty slow, and there wasn't much evolution in the guidelines, whereas within the private sector, there would have been more evolution and drugs like tenofovir coming into play sooner than in the public sector. So starting with our patient is a Mr. DM, a 45-year-old, in fact, this was a black male patient, who was newly diagnosed with HIV. At the time of diagnosis, he was working as a security guard with occasionally doing nighttime shift work. And he was tested because he was admitted to hospital with a pre-renal failure picture as a result of acute gastroenteritis with severe dehydration. As you can see, his CD4 count at the time was 108. He had a viral load down at baseline, which currently we don't do with our guidelines in the public sector. But at this time, in the early rollout of the antiretroviral within the public sector, we in fact did do baseline viral loads. And you can see at that stage, his ALT, so his liver, was pretty fine at that point. If I can take you back a little bit in time, so if we're going to look back and see what our guidelines actually looked like in 2006, now please bear in mind again, this is the very first set of guidelines we had in the public sector in South Africa. So what we were looking at then in terms of treatment was looking at for the CD4 count of less than 200 or a WHO stage 4, so really very, pretty much starting treatment quite late. And in this patient would have qualified by virtue of the CD4 count. And then the what to start with. So these would have been the first regimens that we had with that first set of guidelines. So an NNRTI-based regimen for first line, and the backbone we were using at that time was D4T with 3TC. So at that point, tenofovir was not yet approved in South Africa in terms of the license, and even had it been, at that point, the cost was also pretty high and wouldn't have been rolled out at that point in the public sector. So duly, that patient was actually started. So he started on a nevirapine, and the reason for the selection of nevirapine was because of the patient's job. So he was working as a security guard, doing some shift work. He was obviously also started on some cotrimoxazole prophylaxis on account of the low CD4 count, and so off he goes. About 3 weeks later, our patient arrives and he comes back and he's got an itchy maculopapular type of rash involving the limbs and the trunk mainly. He didn't have any mucosal lesions. He felt a bit unwell, and on a physical exam, there really wasn't a whole lot to see. He wasn't jaundiced. There wasn't really much going on, other than the fact that maybe he had a bit of an upper respiratory tract infection. In terms of looking at some other features, his temperature was 37.1. His ALT had gone up and was about 5 times the upper limit of normal. And when we did viral hepatitis studies on the patient, there was nothing there, so he was fine from that point of view. So at that point, it was decided to actually stop all of his ARVs. In fact, I think his cotrimoxazole prophylaxis was interrupted as well. Everything was stopped at that point. And his ALT settled down very, very quickly. So the liver function returned back to normal, and he was restarted onto treatment. And with the clinician feeling a little bit twitchy because of the ALT that had gone up, actually deciding to now restart this patient onto an efavirenz-based rather than going back to nevirapine. And he does pretty well on this regimen. We do see, because of his shift work, that sometimes his adherence isn't that optimal. And please, again, bear in mind that we are talking in the public sector kind of a setting, so sometimes the adherence support can be spread quite thinly in this kind of a setting. If we look at his progress, we can see that from his baseline viral load of over 500,000, we can see he actually settles nicely and achieves an undetectable viral load. He then gets TB, so his viral load goes up a little bit, but he's doing okay and he settles down. And then we start to hit some hard times. We start to see him from about February 2009, so 3 years down the line, which if you look at surveillance data within South Africa, we can see that the average time for somebody who does fail a first-line efavirenz-based regimen tends to be around 36 months that they tend to fail their regimen. So this is what we can see is happening here with our particular patient. And if we come to where we are now in presenting the case at 2010, you can see that his viral load is massively high. And this would have been despite certain adherence interventions. We do know that most patients actually, when we do start to see the early signs of virological failure, it is usually around the fact that they're not taking their medication in South Africa. That is a challenge. And particularly we know with our men who tend to present late and also do not access the healthcare sector as much or as frequently as women, that sometimes this is more of a challenge. And more often than not, they do in fact suppress with an adherence intervention. But in this particular case, we did not see this. So back in 2010, I mentioned to you we had one set of guidelines, 2004, and then 2010, in fact, the guidelines were updated. So what would have happened with this particular patient is when he was failing, he would have then been switched to a tenofovir 3TC. So tenofovir was introduced into the public health sector in 2010 in South Africa with this particular set of guidelines. And so he was actually switched to a second-line regimen, which was pretty standard in the public sector at that time. So that was an Eluvia-based regimen with tenofovir and FTC going along there. All right. So initially he does okay, and you can see that for a long time he's actually nicely, he's lower than the detectable level, so he's virologically suppressed. Where you can see the red line there is where we kind of lose him for a while. And this is not an uncommon thing. What we don't have in South Africa is electronic medical records. We also don't have something like a single unique identifier, which would enable us, if we had a single unique identifier, to at least be able to track the patients through the National Health Laboratory Service, because all patients who are having tests done within the public sector, in fact, is all done through the National Health Laboratory Service. So if we had that, we would be able to track it. And we do see that quite often this happens with patients. They seem to disappear from care, when in fact they may not have disappeared from care and may in fact have just moved around within the country. A lot of our population is pretty migrant. But he seems to disappear from care, and then he comes back to care in about November 2013, and you can see there at this point he restarts his viral load. He restarts his second-line regimen, and you can see with a pretty high viral load there. And as you can see, he doesn't resuppress on his PI regimen, which again, we probably can attribute this around factors around adherence, because most patients, when we do introduce a good adherence intervention in South Africa, we have strong data coming from cohorts in Clinician and other areas, which actually suggests that around 80% of patients should in fact resuppress on their second-line regimen, even if they have fallen out of care, but not so here. So in terms of, again, using our guidelines, we tend to have quite a fairly strict definitions in terms of second-line failure and how we manage patients. And again, this is around the size of our public sector cohort, where we now have 3.9 million people actually accessing ARVs. So we're fairly guideline-driven in terms of managing our patients. And also a lot of our care has now been task-shifted, with a lot of nurses actually providing care for most of our patients within the public sector. So for a patient to be defined as failing second line, which means in order to be able to access a third line regimen, they need to fulfill these criteria. So they need to have actually been on a PI-based regimen for over a year. They need to have a very good adherence intervention, addressing psychosocial issues, addressing drug interactions, and all of these various factors as well. And after that has been ongoing for 6 months. And the reason that we kind of do that in intervention is to give them sufficient time to suppress, and also because we know that the mutations are going to accumulate relatively slowly in patients who are on a PI-based regimen. And then after 6 months, if we see that the viral load has still actually not come down to less than 1,000, at that point we would then do a genotype. So this is pretty much one of few situations, because of the cost of genotypes and because of the size of our public sector program, we're quite strict in when and where we do genotypes. So at this point, the patient would have had a genotype, and then that would enable them to access our third-line regimen, which I've spoken briefly about. Just to point out to you, third-line regimens only became available in South Africa in 2013. So up to that point, if you were on second-line and failing, you would have been maintained on that regimen just for the benefit that it would have given you in terms of maintaining some suppression and also helping to maintain the CD4 count. But in 2013, we introduced a third-line regimen, which is accessed through a central committee. And what happens is the genotype is actually submitted to a central committee, who will then look at the resistance pattern and determine what regimen the patient should go on. So when that was introduced in 2013, all patients who failed third line were given darunavir. Some would have been given an integrase inhibitor as well. Some may have been given a travarine, and then most patients would also get 2 nucleoside reverse transcriptase inhibitors. So after about a year of the third-line program being operational, in fact, this was streamlined. I think, Gary, you did the streamlining of it all. It was actually developed into an algorithm which was used, and the reason for doing this, well, it streamlined the approach was the one thing, but at some point when you have a program the size of South Africa, it will be untenable for one central committee to actually review all of the failures and decide what treatment regimen was. So the idea was that with time, if you have an algorithm-based approach, in fact, you might be able to decentralize that and be able to maybe farm it out maybe provincially within South Africa. The other thing to mention is our use of integrase inhibitor in third line has also changed. So from 2013, the integrase inhibitor that we would have used would have been raltegravir, as that was all that was available. But as of July last year, in fact, patients who require an integrase inhibitor in their third line regimen, in fact, now are getting dolutegravir. And this is the algorithm, so we can call it Gary's algorithm for today. So what happens in terms of, I want to walk you through the algorithm, and I apologize, there's quite a lot of light on here, so it's not projecting very well. But once somebody has been declared eligible for third line, so going through that second line failure algorithm, then they get their genotype. If the genotype should show that they have resistance to the particular PI which they've been treated with, then if that PI score is more than 15, and here we're actually basing it using the Stanford score, so we input it into the Stanford system and we get that, then they would actually, every patient on third line will get a darunavir-based regimen, and then they will get added to that 2 nukes, which will be 3TC or FTC, which would be determined by what the other nuke is going to be. We will then look at the AZT, so we look at the tenofovir or the zidovudine Stanford score, and whichever of those 2 is the lowest would be the nuke that we would add to it with either 3TC or FTC. Then we go back and we look again at the tenofovir score, the nuke score and the PI score, and if we find that actually there's also some resistance there to darunavir, or if there's some intermediate resistance to the nuke that we have added, it's at that point that we would actually add an integrase inhibitor. And as I mentioned, up until 2013, that would have been from 2013 to 2016, it would have been raltegravir, and more recently dolutegravir. And then depending on how high that level of resistance is to darunavir and to the nuke backbone, and if there isn't much resistance showing to a travarine, then we may add that as a drug. So on the whole, All patients would get a darunavir-based regimen with 2 nukes. Probably about 2/3 of patients actually get an integrase inhibitor added to that as well, and about 1/3 of patients accessing third line would get a travarine added to that as well. So this is all within the public sector. In the private sector, it works fairly similarly, excepting that there may be the option of rilpivirine as well, which we haven't used at all in our public sector in South Africa. Okay, so if we go back to our patient, Mr. DM, and we look at his scores here, so if I take you through that, the scores that we would look at using our algorithm approach, we would actually look at the lopinavir score, so that would be more than 15. In his case, that would mean he would qualify for a third line. We would then look to determine which nukes we're going to use. We look at the AZT and the tenofovir. In this particular case, the tenofovir is lower. And on account of the fact that it's relatively low, but the darunavir score is 25, on the basis of that, we would determine that we'd actually like to add an integrase to our particular patient as well. And so if you actually look at the algorithm again, you can see, if you're looking at the scores there, you can work out the regimen. So what would have happened to this particular patient is Mr. DM would have been started on a regimen which would have been darunavir. Ideally, it would have been tenofovir with FTC, and he would have had dolutegravir or raltegravir added to that particular regimen. And this is what we did with him. And initially, he actually tolerated the regimen pretty well, although, as you can see, it's quite bulky. The third-line regimens are pretty bulky. And a lot of people would argue about that, well, you know, if this is a person who's failed first line, which is challenging, going on to second line with more pill burden, and then you want to take them to a third-line regimen with this with an even higher pill burden. But to be honest with you, in South Africa, if you've managed to get to the third-line selection process, you are pretty resilient and you are hanging in there and you are accessing care. So in fact, actually, we probably see that these patients, in terms of their adherence, are probably somewhat better than some of the patients who don't actually get through to third line in terms of their adherence. So the other issue, of course, is we do consider cost in all of this. So if you look at our overall program of 3.9 million people who are accessing ARVs, in fact, only about 150,000 are currently accessing second line. I don't think that this means that that's all we've got in the way of people who need second line. What we do know is there are challenges with viral loads being done. There are also challenges maybe where viral loads are being done, but not necessarily acted on as quickly. And you could actually see that even in the evolution of this case. He was kept on a failing regimen for quite a long time. And then similarly, when we look at our third-line regimen, our third-line cohort currently is about 600 patients accessing third-line in the public sector, and that's for adults, with about probably 200 pediatric patients. And again, I don't think this necessarily reflects the numbers or the need, but may be, again, around people not necessarily knowing how to access third-line, but also maybe viral loads, again, not being done or not being acted upon once they have been done or just being sat on. Okay, so what I didn't tell you about Mr. DM, and the clue was there all along in his name, is he's actually now, if we come to the present time, or to 2016, say, he's now 54 years old. He's hypertensive, which is a very common comorbidity that we see within our Black African population in South Africa, and at this point has developed type 2 diabetes, which is another problem that we have. It's actually the second leading cause of death currently in South Africa in terms of the massive growth we've seen of non-communicable diseases. Currently, he's on metformin, insulin, and ACE inhibitor with a diuretic in a co-formulation, as well as taking a statin. So this patient is probably, after breakfast, rattles by the time he's taken his pills. And the other challenge you can see is that his renal function has actually been steadily declining, which is not unsurprising, and that prompted him to actually be switched to a regimen where the tenofovir was replaced with the bacavir. And if you looked at his scores, his Stanford scores, you can see he had an intermediate level of resistance to a bacavir with a score of around 40. And I think this is something we suggested for him, is that maybe he might want to find 22 new uses for his pill bottles. It's actually a website that I found, which gives you some interesting things that you can do with your pill bottles. And that's really not the end of his problem. So apart from the fact that he's got the diabetes and he's got the hypertension and then the renal failure that's starting to develop with him, or the chronic renal disease, his viral load was not suppressing either. So at this point, another genotype was done, and at this point we would include the integrase genes. Now, when we do a viral load at second-line failure, this doesn't usually include the integrase genes, and that's really because of the low levels of exposure currently. And in fact, when we do include the integrase gene, it doubles the cost of our genotype. And with the limited exposure that we've had, we don't suspect that transmitted resistance at this stage is a massive problem. But as we start gearing up and moving towards more integrase inhibitor-based regimens, which we should be doing in South Africa towards the end of next year, moving towards a dolutegravir-based first-line regimen, even in the public sector, so we may start to see a shift in this. Please bear in mind that South Africa was also the home of the first resistance in naive patients treated with lopinavir. So I'm holding thumbs. It is our site that actually is doing the big study with dolutegravir in first line, and I think Gary will probably allude to that study a bit in his own talk. So hopefully we broke Kaletra. Let's hope we don't do the same thing with dolutegravir. And what I want to show you here is his current genotype. So his latest genotype, there was actually no change in the reverse transcriptase mutations. Everything there was pretty the same. But you can see he's accumulated some more mutations around the PIs. And very importantly, he's got the Q184, so he's got the one major integrase inhibitor mutation, and then he's got a couple of the secondary mutations as well. So we now sit with the patient who's been exposed to raltegravir, but now also has fairly high-level resistance of dolutegravir and quite a few other dilemmas in terms of his management. He has his comorbidities, so the diabetes, the hypertension with end-organ damage. He's taking lots and lots and lots of pills. The other issue I've not put in here is his work situation, which comes and goes. At times he's employed, at times he's unemployed, so there's a lot of socioeconomic instability in his life. And now, of course, he's sitting with a resistant virus with high-level resistance against all the integrase inhibitors and with intermediate or low to intermediate level resistance against darunavir and the various NRTIs. And for him, there are no further lines of treatment available in South Africa in the public sector. We could, one of the suggestions has been, well, you could look at maybe an entry inhibitor. That's not available in South Africa in the public sector, and certainly we don't really have access to tropism tests. So for this patient, kind of where he is where he's stuck for the time being. So he's not an easy case to manage, and I have to say I could have perhaps presented maybe something a little more happy from our third line. This is perhaps one of the more sad or one of the more disastrous cases, and in fact most of our patients on third line do pretty well, and they suppress very nicely on their regimens, which we use our algorithm to select, but in fact this is one of our cases that we have of acquired resistance around integrase inhibitors. To date so far in the national public sector, the other thing about South Africa is, apart from the fact that we have this diversity of public and private sector, we also have two countries within one country. So I work in the northern part of the country. I work in Gauteng. Gary Martin's in the audience. He works in the other country, which is the Western Cape, which has its own kind of a Department of Health, develops its own set of guidelines, and generally works a whole lot better than the rest of the country. So it is kind of like two countries within one country. And so we have also that kind of a setting going on as well, and so things tend to be managed a little bit differently there. But this is where we are with our particular patient now, and so I just wanted to say thank you very much for your attention.